Hello everybody and welcome to our first very professional Cambridge Health Network Zoom meeting. We were hoping that we would be in person. We were all really looking forward to our first in-person event since coming out of hibernation, but sadly it wasn't to be. But despite that, we are absolutely delighted to have Simon here. For those of you who will remember, our very first Cambridge Health Network event was in June 2004, so 17 years ago. Simon was our first speaker. He has gone from strength to strength since then, and so have we at the Cambridge Health Network. So we're really delighted to have you here this evening, Simon. We have a number of questions that Pam and I are going to ask you. That will be for about the first 20 minutes, 25 minutes, and then we'll have questions from the floor. So to people on the Zoom, there is a little button, I am told, at the bottom of your Zoom screen that says Q&A. So if you would like to submit a question, you press that Q&A button. If you can't find it, then you can shout at your screen and none of us will be able to hear you, or you could call a friend, probably someone a bit younger, and see whether they can find it for you. But hopefully it will work. Please send in questions. We'll have a good 20-25 minutes to answer those questions, and then we will wrap up by 6 o'clock promptly. So Simon, first
Penny.
question. What are you most proud of in your tenure as Chief Exec of the NHS?
Well, I'm most proud of the NHS, and therefore particularly, of course, of everything that the NHS has had to deal with over the last 18 months. And to be proud of the NHS is, first and foremost, to be proud of the staff of the NHS. And so when you think about the extraordinary pressures that COVID has put upon not just hospitals, but across the whole of the health service, and by the way, in other industrialised countries as well, the response has been quite extraordinary. I think the agility, the commitment to going the extra mile that staff have shown, the fact that we've been able to look after more than 400,000 severely ill coronavirus patients, and even at the peak of COVID, for every one coronavirus inpatient we were looking after at least two other patients for other conditions. I mean, that has been an extraordinary response, but it's also been an incredibly tough period. And so I think there are some big lessons that will need to come out of what we've just been through to help future-proof the country, to future-proof the world. And no doubt the time will come when those lessons will be applied.
Yeah.
Cool. Over to me. Hi, everybody. Pam Garside, the other one. And it's great to have Simon here, as Penny said, and welcome to all of you friends, colleagues and students. Some students out there. It's very good. Simon, following on from that, what would your hope be for the NHS in the next 10 years?
Well, there are going to be some immediate challenges coming out of what we've just been through over the last year and a half. We've obviously, like all countries that have had heavy coronavirus inpatient loads, had disrupted care. And so we're going to be needing to respond to that extra elective care, the routine operations, but also the disrupted cancer care, the extra health needs that have arisen, whether it's long COVID, whether it's young people's eating disorders and other mental health pressures. So first and foremost, we're going to be tackling that. But at the same time, we're also, I think, going to be continuing to make the wider changes necessary to help future-proof the NHS. And if the pandemic has shown anything, it is that actually the prescription that says joined up services where different parts of the health service and the care system work together, that has proven itself under the most extreme test of the pandemic. And that, in a sense, was the journey that we were on anyway. So we need to complete what I've called this triple integration, if you like, between what GPs and hospitals are doing, between what the physical and the mental health services are doing, and between the health and the social care services. And if we do those three things, dealing with the backlog, the triple integration, and then the third being continuing to speed up the pace of innovation and adoption across care, then I think looking out over 10 years, there's every reason to think that when we come to celebrate the 80th birthday of the NHS will be fighting fit.
So I don't want to get too political, but one would hope that the social care policy is done with, embedded and progressive and done by then. Yeah? Yes.
I mean, I think there is an increasing sense that the stars are aligning on the need and a prospectus for social care reform. Yeah. My hope is that is not simply about addressing the fairness of the funding burden, particularly for people who go on to have dementia and need care home support and then have to sell their homes, the so-called Dilmot question. Not just that, but also tackling the very significant unmet need that people require in order to live secure and dignified in old age. That we look at the way in which social care is provided with more personalisation rather than some of the binary choices about being at home or being in a residential setting. And we recognise the big workforce challenges in social care and indeed in the NHS, where perhaps 1 in 4 people working in social care are doing on 0 hours contract. There's huge churn. The career opportunities are not as well articulated as they are in the NHS. So it's got to be a comprehensive package in order for social care really to be on a secure footing. But I do think that actually, as I say, the stars probably are beginning to align, given everything that has been revealed very acutely over the last 18 months.
And this question might be duplicative. So if all goes well, your successor might be appointed in the next sort of week or 10 days. What do you think the 3 biggest immediate priorities are? It may reflect what you've just said, but what are the 3 in the inbox?
Well, I think it does reflect those, but I would particularly underline the need to now support NHS staff, not only given the longer term pressures, but particularly, of course, everything that people have been through since January 2020. And in order to do that, we need to learn a lot of the lessons about what the best local employers are doing to support staff currently in post. But also we need to respond to the upsurge in interest in health careers that the pandemic response has inspired in young people. I think, over the last year we've seen a 34% increase in interest in undergraduate nursing, a very significant increase in medical school applications. So young people have seen, under the most demanding circumstances, health professionals and other staff doing amazing things, and we need to provide good routes into the health service for them as well. But also, I might add, we need to make sure that the staff that we've got are fairly and appropriately paid. And so, we've got an independent review body process looking at what is a fair and appropriate answer. And I think all of us very much hope that whatever their recommendations are, they can be honoured.
Thank you. Penny, over to you.
So, Simon, what would your advice be to your successor in terms of how they think about primary care? Much talked about over 10, 20, 30 years in terms of reform. Yeah. What do you think they should do?
Well, as we all know, that's a very big question. Not that any of these other ones have been at all superficial. First and foremost, the foundation of the NHS is primary care, as evidenced by the fact that we have 300 million or so patient appointments and interactions with primary care each year, compared with under 30 million in A&E departments. So primary care really is the foundation of a population-orientated health service. But at the same time, I think there's a recognition that leaving it just to each individual GP practice to try and figure out how best to look after their patient list actually is not the main way in which we're going to need to strengthen primary care. And that's why actually the creation of groups of practices, these primary care networks, with a significant buttressing of other primary care professionals as well as GPs, alongside continuing recruitment and hopefully improved retention in general practice, that strengthening of the primary care pillar of the NHS is vital. And then there are some unresolved debates, which I think we don't collectively yet know the answer to. In particular, what is the right blend of face-to-face care versus telephone or digital? Yeah. And we've obviously seen a huge swing from face-to-face to online and digital and telephone, and now a sort of balancing back. And I think trying to prescribe directively what that mix looks like is unlikely to be successful. But it is clear that we do need to make sure we have the offer of convenient face-to-face appointments for those patients for whom that's appropriate and who would like that as their way into the service.
So we're about to go through another major reorganisation of the NHS, the development of ICSs. Will that work? Will it be a good idea, or is it another rearranging of the deck chairs?
Well, I think the difference in this respect, and I think this is probably true this is probably the first time in the history of the National Health Service actually having sort of, as we all have, looked at these things quite carefully since 1946, not that we were around in 1946, but I joined the NHS on its 40th birthday, not its first birthday, celebrating its 73rd birthday this year. most of those have been blueprints that have been administratively or legislatively imposed on the NHS. This one is a series of evolutionary changes that have been underway now for 6 or 7 years. We have ICSs, we have groups of NHS organisations and their partners in local government, in the voluntary sector, other providers as well, looking at the whole population in their area and trying to figure out what the best way of responding to that is in a proactive way. What we don't have is a sort of legal, a statutory, publicly accountable incarnation for those ICSs. So actually what's happening now is we're sort of doing the final mile. We've gone 9/10 of the way towards that changed way of thinking about the challenge. The final 1/10 is going to be the legal changes necessary to make them publicly accountable and to create the right governance mechanisms. But all of these things are just means to an end. The end is a move towards more anticipatory care, a focus on prevention, being able to tackle inequalities in the way that the vaccine programme has shown us how to do. And these things, to the extent they help that, then they're worth doing.
Yeah, Simon, you mentioned when you started in the NHS management. I know you were on the trainee scheme. I embarrassingly was 13 years ahead of you. I worked at that. So, and I met you first when you were 28. Right. At St Thomas's. I won't quiz you anymore. But since the 33 years you've been in the health service, how's NHS management changed? I mean, we all get, I'm not in it anymore, but we all get lots of brickbats, mostly, some credit. But how do you think it's changed?
Well, actually, when I joined the NHS undergraduate training scheme, there were 3 of us in the northern region who were selected to join the NHS that year, 1988. Of the 3 of us, 1 went on to be a missionary in Moldova, Sue. The second became a Benedictine monk, and he still is at Ampleforth, and the third was me. And so, as they said, on all 3 counts, the selection process was quite poor that year. But in the mid-80s, obviously, a fellow called Roy Griffiths had produced a famous report talking about the necessity of managing the way in which the health service operates, not just assuming that magic will happen as a result of individual clinical encounters. And frankly, anybody who's been in a well-organised outpatient department versus one that isn't, anybody who has had their vaccine in the last 6 months, anybody who can see how you respond to a mental health service in transition, all of those are, sort of management and leadership challenges. But I would make this important sort of further observation, which of course most management in the health service is actually done by clinicians. It is our nurses, our ward managers, it is our medical registrars, it is our physio leads, it is our paramedic. Most management is being done clinically. Of course, it's our clinical directors, medical directors as well. But the truth is, airlines don't just need pilots, and the NHS doesn't just need clinicians. We've got 350 different types of job across the health service, all of whom combine to make it the brilliant service that at its best it is.
And what are some of the issues you've changed your mind on over the years, and over your years in the NHS and then as chief exec in the last 7 years?
Well, it was, John Maynard Keynes, wasn't it, who said, when, the facts change, I change my mind, what do you do? So I would paraphrase that slightly and say, when the challenges confronting the NHS change, we need to change the way in which we respond to them. And so in the first part of the 2000s, when I was involved, as was Penny and a number of colleagues, in thinking through how to deal with the big problem facing the NHS then, which was how do you cut long waits for routine care and expand the number of staff so as to improve the responsiveness of services, the range of things you needed to do then in terms of paying for each extra operation, making sure you've got a range of provision that could do that to expand capacity, hospitals, the foundation trusts that were able to make their own very localised decisions. That, I believe, was the right mix of approaches that history has shown produced the result. Long waits fell from 18 months to 18 weeks. Public satisfaction nearly doubled. But that is not actually, with the exception obviously of dealing with the backlog that the pandemic has induced, that is not the main challenge now facing the NHS, just as, by the way, it's not the main challenge now facing most Scandinavian health systems, the Canadian health system, the German health system, and so on. It is, as we all know, the challenge of an ageing population with many different health problems coexistent, and therefore how do you both look at the whole person in a way that places a real population on generalism, not just specialism. How do you do so over an extended period of time, getting not just waiting for people to pitch up to see their GP or the A&E or the outpatient appointment, but reaching out to support people to make changes that will improve health for the long term. And if you want what in the jargon is called population health management, focus on prevention and inequality, then you've got to redesign the wiring of the health service, and that will look different than it did in the early 2000s. That's a pretty profound change that we're not the only ones in this country, as I say, worldwide. Populations with multimorbidity and ageing are doing the same. So have I changed my mind on that? Yes, to the extent that I think the problem set we're dealing with now is different than the problem set we were dealing with in the early 2000s.
I think the encouraging thing on the previous question is the management trainees I meet, and you must meet them, they're still, they are really high quality. They can probably count a bit better than they used to, and they're better at data than certainly I was. But that's encouraging for the future.
The graduate training scheme is one of the most competitive graduate entry training schemes in the country, probably in Europe. So yes, we're able to attract excellent talent because I think people like the combination of the mission that the NHS stands for, the chance to work alongside and with some really brilliant people, and the range of career choices and the diversity of stimulation occupationally that it therefore provides.
That's a promo for the graduate training scheme.
Yeah, absolutely.
Penny, did you have any more questions?
Final question from me, and then Pam can start looking at the questions that have come.
Can I just say, get your questions coming in.
We've got lots in.
Got lots, but
yes.
I want some on innovation from some of the startups out there, otherwise I might ask
There are
one.
some questions on innovation already.
Good. Okay, thank you.
So one final one, Simon, that's come through on the chat as well. We've been talking about health inequalities for many years. It's 15 years since we had those tube maps showing the difference by a year. Horrendously seen in the last year. I mean, really stark. Do you think we can make a difference? And how long will it take?
Well, I think there are layers of causation, aren't there? So there are some differences that are, some inequalities that are in the sort of immediate action zone for the NHS, and that is particularly around inequalities in access to healthcare. And so I think we are now in a position much more clearly and almost in real time to track differential uptake of preventative services, screening services, vaccination services, early cancer diagnosis, and to stratify that by socioeconomic status, to make sure that there aren't ethnic and race-based differences that are standing in the way of access. And I do think the vaccination programme actually is the signature example of how we're going to need to do this and hardwire this into our approach for dealing with cancer services, mental health, the gamut of the big killers and disablers that are confronting us. And when you do that, of course, what it means is you're not looking in the rearview mirror 3 years after the event, having another, authoritative report from the great sort of researchers on health inequalities. What you're actually doing is you're looking at today's data, this week's data, and you're saying in this part of Bradford, why is it that fewer 34-year-olds from this postcode have turned up? Why is it when you stratify the vaccination uptake by 16 different ethnicity and race groups, we can see these differences, and what are we going to do about it? And that leads you to some very immediate changes that you're designing in as you go. It means you offer vaccines after Friday prayers at the mosque. It means you go to the places where people are, sports halls, community leaders, the third sector, rather than setting up shop behind an NHS building and expecting people to navigate their way to you. And I really think that actually has been such a successful example that now we've just got to generalise across almost the totality of what we're doing.
Yeah, except because what we've had with vaccination is the amazing database. You know, I've seen you can click on it, you can see which streets, you can see which groups of people and so on. So how do we get that for every other disease, every interaction with the system and so on?
Well, that's exactly what... Yes, absolutely.
Yeah.
We've got to invest in the infrastructure. Although, I mean, actually this was done at relatively modest cost, and it was done incredibly quickly because of a sense of urgency, force majeure. And we've got to apply that exact same sense of urgency, you know, by any means necessary, while of course protecting people's individual medical confidentiality in order to get the job done.
Right. This question is, I will name the person because Simon will guess. It's a friend and former colleague of his and ours, Richard Smith.
Richard, how are you?
One of your best legacies will be the Greener NHS programme. How confident are you that the targets of net zero for 2040 and 45 can be reached? And do you think that the government and your successor will continue to see it as a priority?
Well, thank you, Richard. And yes, I agree with your analysis. For those who haven't clocked this as closely as Richard has, and Richard, I think, chairs one of the umbrella bodies that's brought together many of the stakeholders to help lead this agenda. The sort of core process here is that I asked a guy called Nick Watt from University College London to lead a very practical development, of a very practical blueprint as to how we could decarbonise the health sector, the NHS. And he, with his group, including many staff across the health service who actually are very motivated by this agenda, as Richard implies in the question, has come up with what that route map will need to look like. And there are, one way of thinking about it is sort of two categories of actions. There are things that are under our direct control, and there are things where we need to influence others. The things that are under our direct control are things like the anaesthetic gases we use, things like the asthma inhalers that we prescribe, things like the energy supplies that we use across our estate, things like the approach we take to patient transport and travel. But then there are a second category of things where we need to influence others, such as our supply chains. And so we will be introducing into the procurement processes and the contracts that the NHS offers incentives for decarbonising our supply chain, and that will benefit those partners who are able to show that they're doing that when they come to take part in procurements for medical supplies, consumables, other services that we use across the NHS. And frankly, I think those same partners, including in the life sciences sector, the pharmaceutical companies, the diagnostic companies, they are motivated to do so anyway, and a lot of the other countries where they operate are pushing in the same direction. So I think there's a convergence here. We've got the COP26 conference in Glasgow in the autumn. I think that will be an important moment to crystallise what the UK will be doing on this agenda. We've already allocated £260 million of capital to help parts of the health service begin this journey, and there will be more to follow, including from the work that Alok Sharma is leading for the UK government.
We hope that your successors, I know you're very passionate about it and have been leading the charge, as it were. It would be great if your successor was. I'm sorry, I'm looking at this at the same time.
Can I just make one other point, which
Yes.
would have clocked, but I think for those who haven't looked at this quite so carefully, it's very interesting. There was a report out within the last week from the Office for Budget Responsibility, who track the state of the public finances, and they essentially said that the costs over the next 30 years of the UK meeting its green obligations will be no greater than the costs that we've incurred on the pandemic over the last 2 years. So this is the art of the possible.
Yeah. Thank you. Penny, Nick, after I've done this one, why don't we just be spontaneous and you choose one, but I'll choose this one first. Great
Very
session, anonymous attendee. Great session.
I'm sure it's this session.
Simon, what advice would you give a 28-year-old, I hope you are 28, about next moves if you were turning 28 today? I'm imagining in this profession, as it called, NHS management.
Yeah. Well, I mean, being really kind of specific about it, I would say try and do a range of different types of job early in your career, in your 20s. So I greatly benefited from, my first job in the health service was working in a small acute hospital in County Durham, in Consett, and then I had the opportunity to work in mental health in North Tyneside and Northumberland, and then at Guy's and St Thomas's in London, and as a health authority director in New York City Health Department and the Department of Health and Social Care. And I do think having that breadth of experience both expands your horizons, enriches your experience, and gives you a better sense of where you actually then want to put more of your energies. So I think that would be the first piece of advice, to the extent I'm capable of giving any, I would proffer. The second would be, to the extent you can judge it, choose your boss as much as choose your job.
I was to say exactly the same.
Oh, thank goodness for that.
Well, because people say I can't choose
You
your
don't
boss.
have a boss, though.
Yeah, you've chosen yourself.
Damn.
Pam. Yes.
Yourself.
L'état c'est moi.
No, people say I can't choose my boss, but you can actually. Sorry, go on.
Yeah, well, I think that's a good one. And the third piece of advice I think I would say is, in thinking about the next job you take, whatever that next job is, think about whether you have more options at the end of it than you had going into it. So those would be three off the top of my head, but I'm sure there are lots more.
Really good, thank you. Penny, what would you choose?
So we've got a number of questions from a number of people on elective care. And questions are ranging from, did we shut down too much during COVID? Could we have actually kept more elective care going, particularly outpatient diagnostic work and so on? We've got a question around, there were 4 million people on the waiting list before we went into COVID, and now 10, 12, depending on when we count it.
Well, there are 5.3 right now.
Well, but projections are that it's going to go much higher and so on.
Yeah,
and
well,
so
we can
forth.
talk about that, of course, yeah.
And so one bit of that then is what happens over the next few months, if we're already in another wave and so on. But also longer term, does that really potentially risk people losing faith with the NHS as a model of care? And does this become something that almost takes us back to the sort of late 1990s and a massive political issue?
Yeah. So on the first question, I mean, the actual answer is that it was a period of less than 6 weeks in spring 2020 when there was a moratorium on non-urgent elective surgery. And that was because in the second part of March and into April, nobody at that point knew how many coronavirus inpatients hospitals would be facing. So what was done here, which by the way was the same as was done in the likes of Germany and the Netherlands and Switzerland and Italy and other countries facing the same unknown, was to put a pause on those services. But when we got to the second wave in the autumn and the winter we've just come out of, actually hospitals did an incredible job sustaining elective work alongside their coronavirus patients, even though we had 34,000 COVID inpatients in mid-January. Now we've seen a really substantial bounce back coming out of spring into summer. Hospitals are doing about 92 to 93% of their normal elective activity. The remaining gap is principally explained by the output offset from the infection control processes, which perfectly understandably and rightly people are subject to. So if you've got to have a bigger gap between patients for air changes in an operating theatre, if you've got to separate beds and bays in hospitals, that obviously has an impact. But that then takes us to the second part of the question, which is what is the outlook over the next 3 years? There was reporting at the weekend, the new Health Secretary, Sajid Javid, had talked about the modelling that we'd shared with the Health Department, showing that if no action was taken and there was a bounce back of referrals for people who didn't come forward during the pandemic, then the list could get as high as 13 million. But that was not a forecast that the list will be 13 million, because just to be clear, that would only come about if no action was taken to tackle it. And that's clearly not what either the NHS or the government is going to do over the next 3 years. We're going to have a massive mobilisation to expand elective and diagnostic treatments in order to ensure that that's not what happens. And indeed, if you look at even the last several months, I mean, there are some promising signs. The median wait for an operation for non-urgent care, routine care, has fallen from over 19 weeks last July to under 11 weeks now. but it's going to require a huge effort, and it's going to require some new ways of working as well. Quite frankly, we're going to need to really get up and going with the community diagnostic hubs. I commissioned a guy called Mike Richards, who you will all know, to set out what this model might look like pre-pandemic, actually. But the idea that you can go and get your tests, your scans done, perhaps in freestanding high street settings, rather than having to go onto a hospital waiting list to expand that part of the capacity. So, look, I think the lesson of the early 2000s, the lesson of the vaccination programme, is that when the NHS is given the backing it needs, it can get the job done. And I've no doubt that that will be true under this situation as well.
There's some really good questions here. I'm going to combine two of them. Anonymous, what are you most excited about when you see technology applied to healthcare, be it AI, machine learning, analytics and beyond? And then a question from Martin Frost, who you may know, former chief exec, built up Cambridge Medical Robotics to a hugely successful company. And Martin says, is it desirable and achievable for either an individual director of every trust to have responsibility for innovation, and or for there to be a meaningful metric for effective adoption of new technologies as part of management incentives and review? And then he says, thank you, Simon, for the excellent job you've done. So both technology type questions. So what gets you most excited, and how do we incentivize the system and management?
Yeah. Well, if I can interpret technology broadly, so not just technology with a capital T, but the sort of broader range of life sciences innovation, perhaps. I think we are at the point where we are beginning to get very useful practical applications of machine learning into parts of the diagnostic pathway. And we've got something called the NHS AI Lab, which is backed by £250 million. We run regular sort of open and transparent processes for identifying partners who will come and bring to bear their machine learning or AI technologies into NHS care delivery. And I mean, you go on our website, look at some of those. All of them are incredibly exciting. We don't know exactly which of them will end up being scaled to have a huge difference, but in amongst those and others like them lie some big changes in the way in which early diagnosis will take place and screening programs will be redesigned. And in the case of cancer, if I can just expand the technology from a big T to a little t, I think that a significant part of how we're going to get to a position where 3/4 of our cancers are diagnosed and treated at stage 1 and 2, as against a half or 53%, as it has been, is going to be, yes, encouraging people to come forward, yes, expanding a range of things we already know about in colorectal care, breast cancer care and so forth, but some of it is going to come from some very exciting new technologies, including, for example, the detection of 50 different types of tumours in circulating in blood and so forth. Just one example, but I think looked at over the next decade, a significant part of the lift in early diagnosis is going to come from some of those new diagnostic and treatment technologies. Yeah.
And what about incentivising adoption through sort of, suggestions of an innovation director or similar?
Yeah. So look, I mean, I understand the thought, and I think in actual practice, if you go and look across the health service, we've got lots of undeclared innovation directors inside organisations, many of whom will be a jobbing clinician, a clinical director, an enthusiast who will be bringing their colleagues with them and driving change. So I suppose the question is, does formally labelling or appointing somebody inside an organisation help with that? Maybe, although it's such a broad waterfront. I mean, every service, every specialty, every interaction, we want to see innovation. And so, the dilemma always is, are you just compartmentalising and then marginalising if you do that? But there are some clear things that the Accelerated Access Collaborative, which Aradasi chairs, has identified. We have a series of innovations through that AAC pathway that we really want to see uptake. across the health service. And so, yes, using the academic health science networks as part of our sort of adjunct capability to drive innovation is one way into that. But I mean, I think in a number of bigger organisations, they probably have what's been described. So certainly worth thinking about.
Penny, do you have one?
So if we follow on the theme of innovation, but maybe apply it to mental health care.
Yeah.
So sort of gone from mental health being a bit of a Cinderella, at the same time, very radical change whenever 30 years ago, out from the asylums into the community. How could technology allow us to have a similar radical change now? Because it's not really a Cinderella topic anymore. It's sort of probably the most high profile service, really, particularly for younger people. So where could technology innovation play a role in really having a modern day version of fundamental radical change in mental health services? Any thoughts on that?
Well, I think some of that is beginning to bubble away anyway. So we've got online cognitive behavioural therapy, which has been shown to be clinically effective for some people, but equally for others, actually having the therapeutic relationship of a face-to-face encounter over time with a therapist, a psychologist, psychiatrist is an important part of the healing relationship. So again, as we talked about with GPs, I think we've got to be somewhat plural and open-minded as to exactly what that mix will look like. But I mean, the fact is that we've got significant unmet need in mental health. I mean, one of the things I am actually proudest of over the last 7 years is that for the first time in the history of the NHS, we have ruthlessly enforced the requirement that each year investment in mental health services grows faster than that of the NHS budget overall. So mental health as a share of the pie is increasing, but we're going to need that to continue. And I do hope that I'm sure my successor will be as on it as Claire Murdoch and Tim Kendall and I and colleagues have been over the last 7 years. But was there some particular innovation you were thinking of, Penny, on that one?
Well, I suppose if I push that one a bit more, so as you say, there's a lot more money going into mental health, which I think would be recognised given the growth in demand. I guess it's a bit about how do we move that from, exactly as you were saying, from being money in is a good thing to actually, it's not really the money, it's around the services that we can offer. So as you say, could we use digital technologies a lot more? Is that something younger people in particular would be more responsive to? Is there scope? We've never really shone a spotlight on length of stay in inpatient mental health care. Should we be looking at that in a much more radical way? Is there further way to go in terms of some of the real estate changes? I remember a few years ago in the part of London we're in at the moment, we're sitting close to London Bridge. At one stage there were 300 different sites that were providing some form of mental health care just in South East London alone. Does that make sense? Do we need to fundamentally rethink that? How do we think about primary care and mental health? I mean, there's quite a long list of ways in which we could really quite fundamentally change.
So it may not be, it might not all be technology, but in terms of changes in the service model, completely agree. And I think, a case in point would be young people's eating disorder services, where a number of those, traditionally that has involved inpatient stays in sort of highly intensive, specialised facilities. But actually, for a number of young people, that may not be the optimal way of providing care. And there is a question as to whether actually a combined response from general, from paediatric units together with mental health teams, with a sort of credentialing as to what that looks like, would make more sense. So I think that the structure of specialised mental health care has been somewhat inflexible, partly because of inflexibility in the availability of public capital for NHS mental health providers. And I don't think that part of the care delivery provision has traditionally worked well. One of the things that I think has made a difference, is making a difference, but it's by no means mission accomplished, is giving the ability for local mental health services to redesign pathways and then to reinvest the money that would otherwise have been spent on some far-flung specialist unit in a local service, so-called provider collaboratives. And I think there's more mileage to be had there.
I'm not just picking sycophantic questions, but this is from Alwyn Williams. Talk about a successful
Hi, Owen.
NHS management. Alwyn is Chief Executive of the whole BART system.
Absolutely.
And a friend. Simon, firstly, many thanks for your leadership of the NHS for many years. We've greatly appreciated your ongoing direction and support, not least during the COVID pandemic. My question is, how can we encourage and support our talented staff to aspire to be CEOs of the future, and how should we ensure much greater diversity in senior NHS roles?
Yeah. Well, thank you, Owen. And I mean, the work that you have done, not just the Royal London and Barts, but as the bigger Barts group, I think is a very good practical answer to the question that you posed. So I would urge anybody who's not looked at what all has been up to down in East London to go study very carefully, because I think that has provides a significant part of that route map. I think if I take the last part of the question, perhaps as the sort of pivot point, i.e. more diversity in leadership, we now for several years have held a mirror up to ourselves as the NHS through the Workforce Race Equality Standard, and that has shown continuing differences in the experience, unacceptable differences in the experience of being a black or an Asian member of NHS staff compared with being a white member of staff. Some of the differences that relate to core HR processes, likelihood of being shortlisted, likelihood of being in a formal disciplinary, likelihood of having opportunities for discretionary training, they have improved, but the actual lived experience of being a staff member generally has not. And one of the things that I've commissioned with the support of many of my colleagues has been a medical workforce race equality standard, the medical RES, which is, I think, about to be published. And interestingly, one of the things that will show is that the experience of black and Asian minority ethnic medical staff is that their experience of racism and discrimination is to a greater extent from other colleagues in the NHS than it is from patients and members of the public. So look, we've got work to do. I think that would be the sort of understatement of the century. We can be proud of the fact that the NHS is the most diverse employer in Europe, but we need to put on rockets the work that has begun to improve the diversity of our leadership. We've seen significant increases in the number of very senior managers from black and Asian backgrounds, but at the chief exec level, much more work to be done.
So I'm just going to add a very Christine Hancock question here. Has anyone asked why he is leaving?
Well, you just have Christine, so there you go. That's sort of the question inside a riddle inside an enigma. Well, I mean, the honest answer is actually last summer I signalled to my board that I thought 6 years was a pretty decent stint. When I was appointed, I envisaged doing 5 years, but obviously then we had resurgence of COVID, and indeed the autumn and the winter turned out to be far worse in terms of the COVID pressures for the country and for the NHS than what we'd been through in the spring. So I felt it was right to see the NHS through that period until this summer. And I think 7 years is a reasonable stint. I think we've made some significant changes, but in an organisation like the NHS, the work is never done. So the time will come to hand on the baton to my successor, which I hope to be able to do by Saturday, the 31st of July, when I step down from this job.
And go on the Fastnet race, I hear.
Yes, that's true.
Yeah,
yes.
Good. Penny.
I hope you don't get the bad storm. Anyway, I'm just going to take us back. There's got a lot of questions about primary care.
Yep. As in lots of people objecting to what I've said, or
well,
go on, let's have a little controversy.
Including from a lot of GPs.
Okay, go on then. Let's get into it.
Well, no, this is why I'm going to ask you, because I think it's quite interesting. So we've got a few people saying, shouldn't we be putting more money into primary care in the same way we've done with mental health, primary care?
The answer to that, just straight away, is yes, and we are. That's why in the NHS long-term plan, we've made the same commitment on primary and community health spending as we have done on mental health, namely that primary and community health spending will also grow faster than the NHS budget overall, and there will be an extra at least £4.5 billion in real terms by 23-24 compared with the start of the NHS long-term plan.
Very good. So that is an answer to one person's
So
question.
the answer is yes.
Yeah,
Agreed.
so that's one bit. I will also come on to, of course, where we take the money out of and how we manage that.
Well, a rising tide.
Right. So that's the first bit. Second bit is, though, so of course that's money into primary care. It's not necessarily money into GPs. So, which is an interesting one, because there are some questions about, so if future ICSs would like to put more money into, for example, different sorts of services, people are talking about digital solutions to address population health, perhaps even to different organisations doing that, how do they then pull the money out of traditional primary care budgets? Now, you could say, well, you do that from some of the incremental spend, but how easy is that to actually do? And then there's also a question about, is now the time to finish the GP contract with GPs as essentially independent contractors? And should we move to a different model of primary care?
Well, I think we are, expanding the range of disciplines working in primary care, and explicitly there is additional funding for primary care networks to grow the number of therapists and paramedics and particularly pharmacists working directly in primary care. But in my opinion, we will continue to need more GPs, not fewer, and we've really got there are two opposite sides to the story there. Retention of existing GPs, partly given workload, partly given changes in the preferences of primary care doctors, is such that we are seeing younger retirement ages, more part-time working, which is not, is perfectly legitimate, but it's just a fact we've got to recognise, counterbalanced by a really encouraging enthusiasm for entering general practice on the part of young doctors. And I give great credit actually to the Royal College of General Practitioners, who I think 3 or 4 years ago, when Helen Stokes-Lampard was chair of council, and her and Maureen and her successors, and in fact Claire as well, they recognised that actually inspiring young doctors to come into general practice required the profession to be enthusiastic about the complexity and the opportunities in general practice, as well as the NHS itself overall, and that has worked. I mean, we've for the last 2 years in a row, this past year we've had the highest ever number of young doctors going into the GP vocational training scheme that we've had since the health service was set up in 1948. I mean, that's extraordinary. And by the way, is not the experience of lots of other countries. Lots of other countries are still finding more people going into increasing specialist hospital medicine. And I think we've got the potential to begin to counterbalance that. But we've got to get the retention side balanced with the intake of new GPs as well. But in a nutshell, yes, of course, we need to expand the range of services in primary care, not just what GPs are doing. But in my opinion, we're going to need more GPs, not fewer.
Okay, so just a sequitur from that then. So we have this wonderful model comes through over the next 5-10 years. We're focusing more on prevention, we're focusing more on mental health, on primary care, and so on and so forth. And success then is that we need fewer hospital beds. That would be a success model of the future. At the same,
discuss. I've changed.
Discuss.
Actually, that's something I changed my mind on as well. You asked earlier. My base case now, I think, is that actually we're likely to see further increases in the need for hospital provision as well as other services, because we're going to have an expanding health service, and I think. Actually, you can look back. You've done this modelling. You tell us, Penny, when did that inflection point occur? But that inflection point has occurred, I think, hasn't it? Not just in this country, but in a number of others. And so, look, why did we see significant decreases in acute hospital beds in the 80s and the 90s? One reason was because of a big shift in technology, i.e. the move to day case surgery, driven by minimally invasive techniques and fast-acting anaesthetics. So that was a sort of complementary technology shift that reduced length of stay. Is there still an opportunity for some of that in some surgical pathways? Sure there is. But in general, my base case would be that with an ageing population, and indeed, I think one of the lessons of the pandemic being create resilience and buffer capacity, which of course, the health service would like to, but we've not had the wherewithal to do that, rather than running everything so lean.
Can
Which
I
is
ask?
probably
To be
a controversial
discussed.
view. It's probably not the received wisdom, but that is my view, that we're probably likely to actually need
I'm-
more,
Okay.
not less.
But I was asking that in the context of the questions that have come up are around, I mean, maybe changing. How do you feel about the move in the white paper to give more power to a Secretary of State, particularly around changes to hospital provision?
Well, I was asked this question actually a couple of days ago, around the fact that because the NHS is such an important part of British life, it is the subject of political debate. And the question was, is that a good thing or a bad thing? And my answer was, the moment at which it stops being the subject of political debate is the point at which people don't care about the NHS anymore, and that would actually be a bad thing for keeping us on our toes, for driving change, and for the social contract that the NHS represents with the British people. And in any event, aside from that high-minded stuff, the practical reality is that those of us in the NHS, cursing the politicians is a bit like the fisherman cursing the sea. It sort of goes with the territory. That said, I think there is a recognition that there is great benefit in many of these decisions as possible being made locally, being driven by the heterogeneous needs of different communities around the country rather than one size fits all, and having strong clinical leadership. And so what I don't think anybody is seeking is a big centralisation. What we're looking for is the ability to back horses for courses and local decision making to the greatest extent possible.
Can I slide another one in? Because I'm going to get beaten up if I
Let's go with
don't.
the last question.
Yeah, the last one. So Penny and I are very, very keen on measuring outcomes. In fact, I've seen Penny, I think she needs medication when some surgeon in the audience says we can't measure ourselves. I have to calm down. But Rupert Dunbar-Rees, who does very good work in this area, says, will we ever get to outcomes-based healthcare, or more specifically, outcomes-based contracting as part of the routine way we pay for healthcare?
Well, healthcare is so
Big.
big and diverse and complex. The rest of it, I don't think one can give a generalised answer to that. But are there particular aspects to what we're doing where even if we don't pay for the outcome, at least we invest to achieve improved outcomes? I think the answer is yes. And I would argue that actually the cancer plan that we are in the process of implementing, that was set out when Harpal Kumar, who was then with Cancer Research UK, set that. I mean, that is a series of quite practical changes we're trying to drive through cancer care delivery that will improve outcomes. Now, we're not paying for outcomes in the sense that each individual patient episode has an adjuster on it based on the point at which that person was diagnosed and how well they do. But are we moving money around to achieve improved outcomes? Absolutely we are.
And the data's helping us. We've got so much more data.
Yeah,
haven't we?
yeah, we have. So look, I think there's benefit in what Rupert is saying, but actually that's another area I've changed my mind on. Actually, it sounds like so many, and that is that I think one can get overly complex in the design of financial incentives across a health system that don't actually map onto the practical changes that if you're the ward nurse, the thoracic surgeon, the occupational therapist, that's all sort of in the, up here above the cloud layer and doesn't really correspond to your day-to-day work. And so I think seeing it from the other end of the telescope and saying, close to where the magic happens, what is needed to help bring about improvements there. And then, as I said earlier, everything else is a means to an end, rather than starting with a sort of very complex kind of economic incentivization structure and assuming that magic will happen off the back of it. I think I've changed my mind on that as well.
Thank you. Penny.
Well, Simon, thank you. It's been a bit of a whirlwind
roller coaster ride.
50 minutes on healthcare policy and the future of healthcare and so on. So I think certainly very stimulating, as you say. I'm sure lots of topics that people could in a normal world
Thank
could have
you for all the
discussed and
questions,
debated.
everyone. They're
Yes.
great questions. I'm sorry we couldn't get to them all.
We had a number of others on all sorts of philosophical bits about, are we over-medicalising society? Should we all want to die at the age of 75? Sorry, I said 55. Now we would have taken most of
Excuse me,
us out.
I turned 55 on August the 4th, so the answer to that one is no.
Definitely no. Anyway, so fantastic questions from our audience. So thank you very much, audience. And Simon, fantastic discussion and debate as ever. And good luck for the future.
Well, thank you everybody. Yeah.
So, just in our last couple of minutes, thank you very much, everyone, for joining. We are really, fingers crossed, hoping that we will be able to get back to in-person events. We are planning like crazy, so we are hoping to have one on provider collaboratives, provider chains, whatever the latest buzzwords are. We are going to have one on ICSs, are they for real, or are they moving the deck chairs around? We're going to have one on genomics, whether or not that's promise of revolution or not, and how that fits into the whole of the NHS. We will absolutely have something on the future of primary care, and we will keep coming back to data, digital innovation, and so on. We continue to have fantastic sponsors, so big thanks to all of them, and we continue to have a fantastic audience. So thank you all very much for joining, and look forward to celebrating with, hopefully, drinks and canapes and more great speakers in the autumn. Have a good summer.
Thank you.